Alright guys, let's get busy talking about ectopic pregnancies. This is a big topic on exam day. An overview of how we're going to approach this. We're going to talk about where they come from, how they present, how to manage them, and then we're going to cover a differential diagnosis for ectopic pregnancy at the end of our video here. So let's get started with the etiology of our ectopic pregnancies, and if we use our diagram over here, it's going to help us explain a lot. So normally we expect our pregnancies to implant within the uterine cavity, which is going to be here, which I'm outlining. However, in the case of an ectopic pregnancy, it's going to be a pregnancy that implants anywhere except the uterine cavity. So most commonly, they're going to implant here in the ampulla of the oviduct. This is going to be really high yield. They like you to know that it's in the oviduct, also called the fallopian tube, especially the ampulla, where these are going to abnormally implant. However, we can also have implantation in other parts of the body. So we can have implantation out here in the abdominal cavity on either side of the adnexa. We can have implantation here in the cervix. Just about anywhere that is not the uterus will qualify as an ectopic pregnancy. So let's go ahead and review. It's going to be a fertilized egg implantation outside of the uterine cavity, and this is going to be with plus or minus rupture. So sometimes patients will have an ectopic pregnancy that implants in a confined space, aka the ampulla of the fallopian tube. And you can imagine that the fallopian tube is really small, and as a pregnancy starts to grow, it can cause that ampulla, that fallopian tube, to rupture open, and that is usually going to be accompanied by really intense abdominal pain. So continuing on, we talked about the fallopian tube, especially the ampulla being the most common site. I cannot stress how high yield this is for you guys. And then also the abdomen or the cervix are locations, but these are going to be less common. And so when it comes to our risk factors for ectopic pregnancies, we're going to be thinking about anything that led to previous reproductive tract damage, so scarring and fibrosis, especially of the fallopian tubes. And I think the one thing that comes to mind the most for me is going to be pelvic inflammatory disease. So if you have a vignette with a patient who says that they've had multiple partners throughout their life, they've had multiple instances of gonorrhea or chlamydial infections that have led to pelvic inflammatory disease, these are going to be the types of patients that are really at risk for ectopic pregnancies. Now, we also can have previous ectopics that are going to lead to increased risk of another ectopic, because if you had your reproductive tract scarred by a rupture from a previous ectopic pregnancy, that fallopian tube, for example, is going to have a really difficult time smoothly transitioning an egg into the uterus. And then also we talked about pelvic inflammatory disease, and also intrauterine contraception like IUDs are going to be a risk factor, as well as in vitro fertilization, increased age, and endometriosis. These are all additional risk factors, but I would say the big ones to know are previous ectopic and pelvic inflammatory disease. Let's move on to talk a little bit about our presentation now, and usually this is going to present with a missed period. So usually patients will report that their last period was somewhere 4 to 6 weeks ago, when we expect periods to be on the order of 28 days. And then usually we're going to start to see some symptoms of pregnancy, and these symptoms of pregnancy are being caused by release of beta HCG by this pregnancy. We expect these symptoms whether the pregnancy is ectopic or not, because the beta HCG is still being produced. These types of symptoms are going to be like morning sickness and breast tenderness, and these are due to our beta HCG. We can also expect some vaginal bleeding depending on the site of the ectopic pregnancy. So if we had a rupture in some area that caused bleeding, we can expect vaginal bleeding to be a possibility. And then when it comes to abdominal pain, this can be really variable, and this is going to be because our ectopic pregnancy can be up here in the abdomen, it can be somewhere here in the adnexa, or perhaps fallopian tube or the cervix. And we talked about with the pelvic pain line how there are variable nerve fibers serving different parts of our pelvic anatomy, and so this can cause variable reports of pain. And so using the characteristics of the pain to identify an ectopic pregnancy is not the best route, because these can present very differentially. Additionally, in the case of acute rupture, these patients are going to have an acute abdomen. So that's something really important to know, that acute abdomen and signs of shock are going to be a sign that an ectopic pregnancy has ruptured. standard. Now, continuing on, when we talk about our labs, we're going to have urine pregnancy tests be positive in ectopic pregnancy because we know that our urine pregnancy tests are measuring beta-HCG, and ectopic pregnancies are indeed still producing beta-HCG. I would go as far to say that any patient of reproductive age presenting with abdominal pain should get a urine pregnancy test. It's just a great thing to do. It's really cheap and it can tell you a lot and really narrow down your differential to include or exclude pregnancy. So urine pregnancy tests we expect to be positive, and we talked about this being due to beta-HCG. However, there's some important stuff to talk about beta-HCG. We expect beta-HCG to normally double every 48 hours. However, in the case of ectopic pregnancies, it will not double that fast. We're actually going to expect a slower increase in our beta-HCG, and this is because ectopic pregnancies are not comfortable. They are outside of the uterus, so they are struggling pregnancies. So they're not producing beta-HCG as well as an intrauterine gestation would. And that's something that test writers like to ask about. They like you to know that that beta-HCG is going to have a slower than expected rise, as opposed to a normal, which should double every 48 hours. If we were to get an ultrasound, we would see no evidence of an intrauterine gestation. So let's go ahead and review some of our ultrasound findings. If we look here, this is an example of a uterus with a fetus inside. You can see that our fetus is this little lump here, and we can see a little bit of fetal parts here, like a leg and a little arm. And that's gonna be the evidence that a fetus is in the correct position. As opposed to our ectopic pregnancy here, our uterine wall is this structure right here, and then if we look here, our ovary is this guy here, and then we would expect our fallopian tube to kind of connect the ovary to the uterine wall like this, and then you'll see that there is this really big mass here in the middle of what the fallopian tube would be, and that's our ectopic pregnancy, and that is really, really bad. This is a big one. It grew really big, and it probably ruptured this fallopian tube, because if we look down here, we see some blood in what is the pouch of Douglas. And remember, the pouch of Douglas is the recto-uterine pouch, and that is where a lot of fluids will accumulate. So in the case of an ectopic pregnancy, we could expect blood from a ruptured ectopic pregnancy to accumulate in that space. However, other fluids can accumulate there. Imagine you had an ovarian cyst that ruptured. You would expect simple cystic fluid to accumulate in the Douglas pouch in that case. Or we could have like fecal matter if we had a ruptured GI lesion. And so it's important to note that just because you have acute abdominal pain in a reproductive age woman, it doesn't necessarily mean it's an ectopic pregnancy. The pouch of Douglas, which we can sample fluid from, can be really great in helping us figure out what's going on. In terms of the management of our ectopic pregnancies, it's really going to vary on the size of the ectopic pregnancy and where it is. And step one isn't really management heavy, so I want to tell you guys about the options for management, but it's unlikely that you'll be asked to have specific management guidelines memorized here for ectopic pregnancies. I want you to know that methotrexate is an option for ectopic pregnancies that are early and small, and essentially methotrexate is going to be a folate antagonist, and we know that developing pregnancies are really dependent on folate, and so if we give them methotrexate, it essentially starves them of the folate they need, and these are going to die and regress. And so we can use those in early ectopic pregnancies, but this is going to be contraindicated if we have a breastfeeding mother. And then if we have larger ectopic pregnancies that are really big, like the picture that we looked at here in our ultrasound, where we need to have some surgical management in order to control bleeding and remove the ectopic, we can go ahead and pursue surgery for these mothers. And then additionally, in ectopic pregnancies, we want to administer RhoGAM in order to prophylax against RH incompatibility. Now let's move on to talk about our differential, because I think the differential diagnosis here for ectopic pregnancy is really broad. Remember, one of the first places we want to start is getting a urine pregnancy test, because this can rule out the possibility of pregnancy and all of its associated pathologies. When it comes to appendicitis, appendicitis is going to present with lower quadrant abdominal pain, very similar to how ectopic pregnancy might. So getting that urine HCG, getting an ultrasound to look for evidence of an intrauterine or extrauterine gestation is going to be a really great way for you to differentiate from appendicitis. When it comes to ovarian cyst rupture, we could expect to see fluid in the pouch of Douglas. This would be fluid from the ovarian cyst, and in ovarian cyst rupture, we would not expect a positive beta HCG. It is possible to have a ruptured ovarian cyst during pregnancy. However, I do not see test writers writing such a convoluted question. Usually, if they were going to write a question about ovarian cyst rupture, they would mention that beta HCG is negative. So I just wanted you guys to be aware of that. But I think in the case of ovarian cyst rupture questions, you would expect beta HCG to be negative because it's not testing a pregnancy pathology in that question type. And then in our molar pregnancies, we're going to expect symptoms of pregnancy, missed periods, maybe an abnormal uterus shape, and then additionally we're going to expect really high levels of beta HCG in these pregnancies. They are all defined by beta HCG, and so we're going to expect really high levels in molar pregnancy as opposed to low levels in our ectopic pregnancies. And then finally we have our spontaneous abortions, and spontaneous abortions are going to occur when intrauterine gestations fail to progress for some reason or another. And we're not going to go into all of those reasons, but essentially if we were to put an ultrasound on this patient, we would expect to see evidence of an intrauterine gestation like we see here. However, it's just failing. So you may see an open cervical os with products of conception coming out of that open cervical os. Our beta HCG would indeed be positive, but we wouldn't see the other things we expect in ectopic pregnancy, like absence of an intrauterine gestation and a beta HCG that fails to rise at appropriate levels, things like that. So in terms of our high yield review, I think it's super important to know that ectopic pregnancies can occur anywhere outside of the uterus, but it's going to be most common in our fallopian tube, specifically the ampulla. And then in terms of presentation, it's important to know that our presentation can be broad, but we're always going to have a positive urine pregnancy test, and that is going to have a slower rise than expected. I would say that's a high yield detail, as well as being able to recognize an acute abdomen. And then finally, we talked about management, which can either be medical with methotrexate or surgical, and it's important to prophylax against RH incompatibility. And then in terms of our differential for acute abdominal pain in a reproductive age person, it's important to get a urine pregnancy test and then take a look with ultrasound to see if we have evidence of intrauterine gestation. If you use those 2 points in terms of diagnostics, that can really narrow down your differential and help you get test questions right. So I hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye.